acting on respiratory system, we have seen the drugs for the bronchial asthma. Now let's start with the drugs for cough. So let's see first introduction. What is cough? So cough is a protective reflex. Its purpose being expulsion of respiratory secretions or foreign particles from air passages. It occurs due to stimulation of mechano or chemoreceptors in throat, then respiratory passages or stretch receptors in the lungs. Now, cough may be useful or useless. So, useless, we are calling it as a non productive cough, and it should be suppressed one. And useful, that is nothing but the productive cough, which serves to drain the airway. Its suppression is not desirable, may even be harmful, except if the amount of expectoration achieved is small compared to the effort of continuous coughing. So, apart from specific remedies like antibiotics, cough may be treated as a symptom, that is the non specific therapy with different classes of the drugs. So, here are some cough etiology. We will see just the list of this etiology, and in the last of this lecture, we'll see how this etiology can be treated of which class of drug. So, basically, this cough etiology is upper loop and lower respiratory tract infection, then post nasal drip due to sinusitis, then rhinitis, then smoking or chronic bronchitis, also pulmonary tuberculosis, then asthmatic cough, then gastrointestinal reflux, and also the for due to drugs like a captopril and iodides. So let's start with the cough drugs. That is what we have discussed about. The cough may be treated as a symptom, that is a non-specific therapy with this type of dosage forms. So in this, total four types are there. So first is a pharyngeal demulcents, which includes lozenges, cup drops, linctuses containing syrup, then glycerin and licorice. In the second class, expectorants, that is the we are also calling it as a mucokinetics. Here again it divides into two types, that is bronchial secretion enhancers. It contains sodium or potassium citrate, potassium iodide, guaifenesin, that is nothing but the glyceryl glycolate, then balsam of tolu, Vasaka, and ammonium chloride. And the second class contains mucolytics in under the heading expectorants. These mucolytics are bromhexine, amroxol, acetylcysteine, and carbocysteine. Then third class of this non-specific therapy is antitussives, which are also known as cough center suppressants. These are opioids, then codeine, folcodeine, also non-opioids class is there under antitussives heading, that is a noscapine, then dextromethorphan, then chlorpheniramine. And the third class is the antihistamines under antitussives heading. It's a chlorpheniramine, then diphenhydramine, and promethazine. And the last fourth one in the non-specific therapy is adjunct antitussives. It has a bronchodilators, that is a salbutamol and terbutaline, what we have seen in the drugs for bronchial asthma. So these are the drugs for the cough which comes under non-specific therapy. So let's start with the demulcents and expectorants first. Now, pharyngeal demulcents soothe the throat and produced afferent impulses from the inflamed or irritated pharyngeal mucosa. Thus, it provides symptomatic relief in a dry cough arising from the throat. And expectorants We are calling it as a mucokinetics. These are the drugs believed to increase bronchial secretions or reduces viscosity, which facilitating its removal by coughing. Simple. So these are the differences between demulcents and expectorants. Here now sodium and potassium citrate are considered to increase bronchial secretions by salt action, and potassium iodide is secreted by bronchial glands and can irritate the airway mucosa. Prolonged use can affect thyroid function and produced iodism. Then it is rarely used nowadays. Then guaifenesin, Vasaka, tolubalsam are plant products which are supposed to enhance bronchial secretions and mucociliary functions while being secreted by tracheobronchial glands. Then ammonium salts are nauseating, then reflexly increase respiratory secretions. These are the variety of expectorant formulations containing an assortment of the above ingredients and often in combination with antitussives or antihistaminics are marketed and promoted, but objective evidence of efficacy of this is non-conclusive yet. So this is about the demulcents and expectorants. Now let's move towards the mucolytics, second class of non-specific therapy. Here bromhexine, it is a derivative of alkaloid vasicin obtained from Adathoda vasica, Vasaka family, is a potent mucolytic and mucokinetic and which is capable of inducing thin copious bronchial secretion. Then it is depolymerizes mucopolysaccharides directly as well as by liberating lysosomal enzymes, and network of fibers in tenacious sputum is broken through this drug, and it is particularly useful in mucus plugs which are present. Then side effects are rhinorrhea and lacrimation, gastric irritation and hypersensitivity. The dose for this is 8 mg tablet TDS in children 1 to 5 years, 4 mg BD. 8 mg is the dose for adults. Then 5 to 10 years children, it's 4 mg TDS. Now let's start with the ambroxol. It's a metabolite of bromhexine having similar mucolytic action as well as uses and side effects. It's the same as bromohexane. The dose for this ambroxol is 15 to 30 mg TDS. Various brand names available in the market like Ambril, Amrolite, Amrodil, Mucolite, which are having 30 mg tablet, then 30 mg per 5 ml liquid, 7.5 mg per ml drops are available in the market. Then here in acetylcysteine drug, it opens disulfide bonds in the mucoproteins present in sputum and makes it less viscid, but has to be administered directly into the respiratory tract. So the dosage form, this is a mucomix 200 mg per ml injection in 1 to 2 or 5 ml ampoules. Injectable solution may be nebulized or instilled through tracheostomy tube. So it's a specific dosage form. Then carbocysteine, it liquefies viscid sputum in the same way as acetylcysteine. What we have seen in the acetylcysteine, it opens the disulfide bond in the mucoproteins which are present in the sputum. So it acts in the same way, it liquefies the viscid sputum in the same way as acetylcysteine and is administered orally, almost 250 to 750 mg TDS. Then some patients of chronic bronchitis have been shown to benefit. Side effects of this carbocysteine are GI irritation and rashes. Then the brand name with the Mucodyne and Carbomox are available in the market. The Mucodyne is say 375 mg capsule and 250 mg per 5 ml syrup. It is also available in combination with amoxicillin and cephalexin for the treatment of bronchitis, bronchiectasis, then sinusitis, etc. etc. So this is the brand with this carbocysteine drug is a Carbomox. That is a carbocysteine 150 mg plus amoxicillin 250 or 500 mg capsules. Then in Carbisafe, carbocysteine 150 mg plus cephalaxine 250 or 500 mg capsules. So this is about the mucolytics. Now let's see the antitussives. These are the drugs that act in the central nervous system to raise the threshold of cough center or act peripherally in the respiratory tract to reduce T-cell impulses or both these actions. Because of they aim to control rather than eliminate cough, antitussives should be used only for dry, unproductive cough, or if cough is unduly tiring, disturbs sleep, or is hazardous, then only we are using antitussives. That is like in hernia, piles, cardiac disease, ocular surgery. So this is about the antitussives. Now this antitussive, it's opioids. It contains opioids, codeine. It's an opium alkaloid, qualitatively similar to but less potent than morphine. It is more selective for cough center and is treated as the standard antitussive, which suppresses cough for about 6 hours. And the antitussive action is blocked by naloxone, indicating that it is exerted through opioid receptors in the brain. This is the mechanism of action for the codeine of a opioids class, which comes under the heading antitussives. Abuse liability is low but present in the mild condition. Constipation is the chief drawback. At higher doses, respiratory depression and drowsiness can occur. Driving may be impaired after taking these drugs. That's why the instructions are there. You should avoid the driving. Then, like morphine, it is contraindicated in asthmatics and in patients with a diminished respiratory reserve. The dose for this is 10 to 30 mg in children 2 to 6 years and 2.5 to 5 mg in the 6 to 12 years, then 5 to 10 mg frequently used as a syrup codeine phosphate, and then codeine is a 15 mg tablet is also available, and also in the form of linctus the dose is 15 mg per 5 ml. Now coming to the non-opioids class, that is noscapine, that is also known as narcotine. And this is an opium alkaloid of the benzoisoquinoline series. It depresses cough but has no narcotic or analgesic or dependence inducing properties. It is nearly equipotent antitussive as a codeine, especially useful in spasmodic cough. Headache and nausea occur occasionally as a side effect after taking non-opioid drugs. It can release histamine and produce bronchoconstriction in asthmatics. Dose for this is 15 to 30 mg for children 2 to 6 years, then 7.5 mg, then 6 to 12 years 15 mg. The brand name with the Coscopine 7 mg per 5 ml syrup is available. Then Cosco tabs 25 mg tablets are available for this. Then let's move toward the next drug, dextromethorphan. It's a synthetic compound, the D isomer, and has a selective antitussive action which raises threshold of cough center, while L isomer is a analgesic. Now dextromethorphan is as effective as a codeine and does not depress mucociliary function of the airway mucosa, and is practically devoid of constipating and addicting actions. The antitussive action lasts for around 6 hours, and it is not blocked by naloxone, therefore not exerted through opioid receptors, this dextromethorphan. Then side effect of this dextromethorphan is a dizziness, nausea, drowsiness, ataxia, and the dose is a 10 to 20 mg. In children 2 to 6 years, the dose is 2.5 to 5 mg, and 6 to 12 years 5 to 10 mg. Then let's see about the chlorpheniramine. It's centrally acting antitussive with slow onset and longer duration of action, and the same side effect as a dextromethorphan, that is a dryness of mouth, vertigo, and irritability. Then come towards the antihistamine class. Many H1 antihistamines have been conventionally added to antitussive or expectorant formulations. We'll see in the next slides. They afford relief in cough due to their sedative and anticholinergic action, but lack selectivity for the cough center. They have no expectorant property, may even reduce secretions by anticholinergic action. They have been specially promoted for cough in respiratory allergic states through their lack of efficacy in asthma. Then here chlorpheniramine, that is a 2 to 5 mg, and diphenhydramine 15 to 25 mg, and promethazine is a 15 to 25 mg dosage forms are available. The brand name with Finnegan, it's a 5 mg per 5 ml. Elixir is also available. These are commonly used dosage forms. Then second generation antihistamines like fexofenadine, then loratadine are ineffective. Then moving towards the bronchodilators, this bronchospasm can induce or aggravate cough. Stimulation of pulmonary receptor can trigger both cough and bronchoconstriction, especially in individual with bronchial hyperreactivity. These bronchodilators relieve cough in such a individuals and improve the effectiveness of cough in clearing secretions by increasing the surface velocity of airflow during cough. They should be used only when an element of bronchoconstriction is present and not routinely, but their fixed dose combination with the antitussives are not satisfactory because of differences in time course of action of the components and liability for indiscriminate use. So this is all about these drugs which are used as a non-specific therapy in the cough. There are some antitussive expectorants combinations are also available in the market, that is Asthalin expectorant. It contains salbutamol 2 mg, guaifenesin 100 mg per 10 ml syrup, and the dose is 10 to 20 ml. Then Ascoril C is available in the market, that is a codeine 10 mg, chlorpheniramine 4 mg per 5 ml syrup. Then Axalin is containing Ambroxol 15 mg, guaifenesin 50 mg, salbutamol 1 mg, menthol 1 mg per 5 ml of syrup. Then bronchosolvin formulation is there, that is a guaifenesin 100 mg, terbutaline 2.5 mg, bromhexine 8 mg per 10 ml suspension. So there are a lot of marketed formulations available. You can take a note on that. If possible, definitely we will have a separate discussion on this all formulations and the drugs. So this is all about the cough and its drugs, non-specific therapy which we are using with the different types of drugs as well as with the combination of the drugs. Now whatever we have seen in the cough etiology, we will discuss it in detail This is the chart of the etiology of cough, which upper and lower respiratory tract infection. So treatment approach we are going to see here for the upper and lower respiratory tract infection, we are using appropriate antibiotics. Then for smoking, chronic bronchitis, cessation of smoking or avoidance of pollutants. Then pulmonary tuberculosis, anti-tubercular drugs are available. Again, this tuberculosis, different types of MDR and XDR drugs are also available. Then asthmatic cough, inhaled beta 2 agonist, we have already seen ipratropium, corticosteroids. Then postnasal drip due to sinusitis is an antibiotic, nasal decongestant. Then H1 antihistaminic drugs, what we have seen. Then in postnasal drip due to allergic and perennial rhinitis, avoidance of precipitating factors, then corticosteroid nasal sprays are there. Then H1 antihistaminic drugs are also there. Then gastroesophageal reflux, bed head elevation, then light dinner, diet modification. Generally, these are the primary criteria to control the gastroesophageal reflux. And then H2 blocker, proton pump inhibitor, and cisapride like drugs can be given. Then in ACE inhibitor associated cough, it's a substitute ACE inhibitor by losartan, calcium channel blocker, and NSAID. So this is all about the cough. And here we are completing the chapter, that is drugs acting on respiratory system in the pharmacology. Thank you.